Good afternoon. It's a lovely day to be in Barcelona, especially if you're from England, where the weather is not quite the same as here. And I am from England. My name is John Deverill. I work in GE Healthcare, and I lead a team of people within GE Healthcare focused on making partnerships in healthcare with a view to achieving solutions together. And with me, I have two colleagues who will also be speaking later on, so it'll be their turn to have the eternal relief and the freedom of taking their masks off. And the first is Teak, who'll wave at you now, and the second is Esther, although I think they may be speaking in a different order. Now, I'm not going to talk to you about partnerships and solutions. That's not the subject here. What we're going to talk to you about is stress, and what we believe it is necessary and helpful to do to relieve the incredible stress on hospitals and hospital systems everywhere in the world, brought right into focus in the time of COVID. At this point, we find out if this thing works. It does. That's amazing. I have passed my first test because nobody told me how to use this thing. Okay, so you will all be very well aware that there's a pandemic which has gone on and is having a really awful impact on the world. You will all, with me, have seen the programs on television from hospitals all around the world of doctors, of nurses, administrators, chief executives facing incredible stress because the sheer volume of patients has not been matched by their ability to deliver the care which those patients themselves need. But this isn't, it's brought into focus by COVID, but it's not COVID specific. This problem right at the heart of healthcare in the world is that the demand goes up, the level of resource needed to meet the demand can't keep up. It's the same everywhere in the world, and as I said, I work across Europe, Middle East, and Africa. It's a consistent theme. It has been that way pretty much over my lifetime. It will be that way, I'm sure, until the end of my lifetime, whenever that shall be. But we have a frail population assaulted by a pandemic, which may not be, according to many, the last that we see. We see that some hospitals with new technology, with a focus on digital, have coped unusually well. Depending on the technology, it's a real thing. There's a quote on the screen behind me from Newsweek, that well-known health management publication, but it isn't about that. It's not about Newsweek. I think every consultant you speak to will say of COVID, it's accelerated change in the delivery of healthcare. It's brought about a revolution in the use of the E channel, and we've seen those things in the right. New platforms. People now are scared to go to hospital. This, because hospitals are far more dangerous places than aircraft, is not necessarily always a bad thing. It's in some hospitals, some healthcare systems, it's what they've been trying to achieve for a very, very long time. But other things, and we're in Spain. Spain is, for me, in Europe, Middle East, and Africa, it's the natural home of integrated care because of your progress, and I think that was the previous session in here. That's seen as part of the solution now. There's a focus on digital, and there's a great worry about workforce. Some of you may be chief executives. Most of my customers are chief executives. To a man and woman, they're worried about their staff because of the stress. So, technology can work. There's something, as I said, I was looking at for another reason at a web page about Tan Tock Seng, which is in Singapore, where they built something called a command center, which will be a central theme to what we're going to talk about today. Tan Tock Seng has coped extraordinarily well with the pandemic compared to the other hospitals in that great country of Singapore. We've seen the same everywhere where we've built command centers. And elsewhere where they have a similar approach to using digital as an enabler to make staff's lives better. And again, that might be Newsweek, or it might not be, I don't know. Technology isn't only the best way, it may be the only way for the reasons that I'm going to talk about in my introduction. As I said, the impact is huge. We have the challenging dynamics of what's going to happen later today, or tomorrow, or next week, or next month, as you run your hospital in the middle of all of this. We have hospital systems, particularly in the emerged world, where hospitals have been around for a long time, where existing models are incredibly inefficient from a managerial perspective, but almost impossible to break out of, because a way of delivering medicine which has evolved over hundreds of years is very, very difficult to break. It's easier in emerging countries quite often to do that. Medicine is an incredibly data-rich environment. There are oceans of data. And the impact of all of that, because the data is so siloed that the data itself is part of the problem now. It's contributing to the stress because of its inaccessibility that people have to deal with. And the impact, as it says there, increased burden, inefficient staff, patient throughput. That's a terrible set of words in a way. I think it was written by a management consultant probably. It's not about patient throughput. It means that people who need care aren't getting the care, because although there's enough capacity in the system to deal with them, it is so inefficient they won't be seen in time, and some of them may die. It's real. It's about people, and the stress on the caregivers of having to deal with this kind of situation is intolerable. It's called staff burnout. Now, initially, I didn't write this presentation. It was given to me as my gift as I came here today, kind of thing. But so I had to look up what is staff burnout. Staff burnout is when there is stress which is ongoing and irredeemable. It can't be sorted out because the situation is beyond the ability of the person to control it. That results in burnout, which results in disengagement, lower productivity, absenteeism, etc., etc., etc. The person, the doctor, the nurse, the administrator, they become separated from the organization they're supposed to serve. That is a big problem. And as you will detect from my fantastic English accent, I'm British. I know the NHS very well. My wife is a doctor in the NHS. The level of stress, of absenteeism, of everything to do with what one might classically call staff burnout is there to be seen. And it's also to be seen, has been seen in this country and in Italy and across quite a lot of Europe, really, everywhere where this impact of the acceleration of COVID has had a real effect. So I work in GE Healthcare. It's a great and very complicated company, but we believe that we have to do something about the people, about the staff. And okay, we have a technology solution which can help do that, but we have to reduce the amount of time and stress that healthcare people have to spend in looking at data to work out what to do next, because the technology exists now to do so. And so it's almost like a civic duty, I think, that we take advantage of the opportunity that exists to make people's lives better. That's what it's about. I'm very used to saying next slide, please, but instead I'll go click. So that's the essential thing we're here to talk about today. It's how, as I said, this is about stress. How do we reduce the stress of what is already a pretty miserable job for some people and make their lives better and patients' lives better using technology for what technology is supposed to do? So I've mentioned data. I think, I've been working in healthcare for far more years than I care to mention. I was a mere boy when I started, not quite true, but I've been doing this for a while. Most hospital systems I know about have hundreds of information systems. It's sometimes as high as 300. It's never really less than 100. The systems are all very well designed by very professional companies to deliver the purpose for which they exist. Very few of them talk to each other electronically. The trouble is that if you're looking at a patient life, you have to use many of these different information systems at the same time to figure out what has happened and what needs to happen next for the patient. So some of the systems which exist are shown there. The EMR is a classic one that's unusually well integrated, but the troubling thing is, of course, which I may have been naive, but I thought that an EMR was fine. It's an EMR, but actually there are different versions of the same EMR, and quite often they don't even talk to each other, and they might coexist in the same hospital, let alone all these other systems which are shown there. So there's no problem with data, except data is the problem. There is too much of it. So I like to use this analogy because I'm aware that being in Spain, you'll all be a very highly educated and civilized lot. So just imagine an orchestra. This is I think this might be the London Symphony Orchestra, but I don't know, where the people with the instruments are the hospital managers. They all know how to manage their instrument very well. They all have a piece of sheet music in front of them. Unfortunately, these guys are deaf. They can't hear what the other players are doing, and there is no conductor. So it is absolutely certain that in this analogy, the orchestra will get through to the end of the piece of music. It is also pretty much certain that it'll be chaotic and it'll sound not very nice. If it was designed to be Beethoven, it'll sound more like Schoenberg or whichever musical analogy you want to use. A hospital will have its 200 or 300 information systems. It will have about 50 managers. There'll be bed managers or nurse coordinators or discharge managers or whatever it is. Those managers spend most of their days these days, unless, it's not the same in every hospital, but quite a lot of them will be ringing each other up, going to go and see each other. They'll be paging each other. In some cases, they still send each other faxes, which faxes are, of course, extremely secure. That's a very good thing. Difficult to interfere electronically with a fax, but that's about all that can be said. And meanwhile, all the information they need should be available at the touch of a button, but it isn't. So they spend ages and ages and ages stressing and figuring out how to get their patient who is ill and possibly dying into a bed or into the next level of care or whatever it needs to be. It is stress. So, same slide as before. At the bottom are all those information systems. This is, I would choose to put, Daniel Barenboim or somebody to complete the analogy. But on the other hand, you might not all be classical music aficionados. There is a way. There's a way which exists already, which was invented, I think, first probably by NASA, because launching a satellite is quite a big deal, where it's possible to extract from each of these 200 information systems just those little bits that you need. It's actually a very, very little bit from each of these systems, and to present that in real time to the person or team that needs to make the decision to move the patient on to whatever they need to have happen next. And even better than that, you can take those little bits of information, say you've got 20 data fields to decide what to do with a patient, but you have to find the right 20 data fields from the 200 information systems and present it in real time to somebody who's already very highly stressed, and present it beautifully so they understand intuitively what to do. So the technology exists to apply AI to those 20 bits of information and suggest, based on the patient, the history, what's going on, the next thing to do with them is, and it gives them a recommendation. So it's not just data extraction, it's adding real value, and that is real-time optimization. And that saves stress and saves lives and does all sorts of other good things as well. G is very good at this, so I would say this, wouldn't I? It's not, but as I said, Tang Tok Seng, I quoted as a random example, that hospital did it for themselves. It's taken them 14 years and they still haven't finished. So, I think it's important to make this distinction. There are many hospitals where you can have a screen on a wall and it's got data on it, and they say, we've got a command center. And in fact, what they have is data on a wall which may help some of them to manage. It may help show trends and things like that. Well, it's not the same. I'm not saying it's bad, but it's not the same as saying to somebody charged with a person's care, for this person, this is what they need to have next in order for them to be the best they can possibly be. So it's in this graphic, and again, I'm not sure I claim ownership of this one. I'm more the classical music person. It's like the sat-nav in a car compared to a graph showing how bad COVID is. I think that's what it is at the bottom. It's predictive, it's forward-looking. If you look at the design, actually, of a sat-nav, it's minimal information, it's beautifully presented. You can glance at it, you know what to do. That's how the best command centers are. So we're going to talk a lot. We've got two fantastic experts here to talk about this. In the ideal world, if you had a fantastic command center for a hospital and everything was going brilliantly, there'd be nothing shown on the screen because there would be no actions at patient level necessary left to be recommended, unless, of course, you'd run out of patients. So, benefits. And these are quantifiable, some of them. So first, reduce pressure, fairly intuitive, but these things, they save time and money, they increase flow and quality of care, they bring teams together. That's what command centers can do. And it's abstracting data and adding value to it to make people's lives better, both the staff and ultimately the patients as well. I've only got a few more slides in my long introduction before the experts get going, so there we go. So 3 facets. GE's been doing this for a long time. GE, I think, although I've been in GE about 12 years, GE bought a company that did this stuff or co-created something with Microsoft a long time ago. And there is a little bit of a genius, in my opinion, in the way the whole thing is designed. But right now, it's evolved. It's evolved very strongly from the thing on the right, which is called capacity strategy, which is where we started. And I'll come back to that in a minute. The thing on the, maybe there's a pointer on this, I don't know. I'm reluctant to press any buttons just in case. So the one on the left, Central Command Center, that's the one like NASA have. There's an intrinsic power in bringing people together because they make decisions together. They can say, oi, George or Mary, look at that screen, what shall we do? As opposed to waiting to go to the water cooler to have a conversation. They're together. It's very good for team building. So those 50 managers I mentioned in a hospital, just putting them in a room will reduce the stress. With screens so they can see their information systems. It works. Even if you don't add any value other than that, because they don't have to ring each other up. They don't have to send each other texts, and they can just talk. So that is a pretty obvious thing to do if you think about it, but almost nobody does it. That's where we started, based on the NASA experience, the one on the left. The one in the middle was when some hospitals don't like to have a central command center. They prefer to have a more distributed approach to command and control. And that means that the same value, those same 20 bits of information are there. The artificial intelligence is still there, but instead of being presented in a room, it's on iPads and phones and with each caregiver, so that you have a distributed way of making the same information. The only thing you lose is the benefit of bringing people together. It's pretty damn effective in its own way. So when the experts, I'll stop calling you experts in a minute, but when Teak and Esther speak about it a bit later on, we've got one example of each of those. And the one on the right, which is where we started, it's a simulation of how a hospital works. Looks forward weeks and months to within 90-something% accuracy, saying what will happen next. And that's part of the AI that feeds into the 20 bits of information. That's part of the magic, the engine that makes these things really, really effective, because it's not just presenting information elegantly, it's applying some snazzy AI to it in the same way that my toothbrush now knows more about me than I do. The potential of AI to transform is real. I'm not sure my toothbrush really does that, but my car, for example, has got a lot of AI in it. So this is kind of what they look like or can look like. These are examples beset with terminology, because of course every field of expertise has its terminology. These are centralized command centers. I don't know offhand where they are, the team will know. The screens we use are called tiles. That was a non-digital pointer in action, kind of thing. And I understand that RN stands for registered nurse. The fact is that there are hundreds of hospitals now who have these things, hundreds. So what was once a good idea, this is an innovation which is turning into implementation. And then these are the connected ones. These are the ones, you'll be aware of things like ward rounds and multidisciplinary team meetings where experts gather together to make a decision about what should happen next and that kind of stuff. These are the individual tiles of information that people carry around with them. And I don't understand half the acronyms known on this thing, but well, intensive care unit, downgrade, Huddle, possibly. There's a whole set of terminology, which the trouble is, of course, all hospitals are different and have their own sets of terminology. I'm sure that terminology varies across all the different provinces of Spain, let alone going into the US and everywhere else we go with this stuff. So just a word on benefits, I think. So 250 hospitals so far. Here are some impacts. Now, it's interesting, I always think by increasing flow, because this really, what it does, it increases the number of patients you can see in a day. That's good for the patients because they get seen, they get treated. It's also good for the managers because they get less stress. And also for the hospital manager, it can be good because you can save money or make money depending on how you get paid, but it depends on how the hospital gets paid. But the fact is, if you go to a command center, a real one, the one, and I've been to many now, what will strike you is that it's incredibly quiet. It's not like a call center where everybody's talking to each other. They just know. It's incredibly peaceful because the AI and the 20 bits of information I mentioned and all that stuff is happening automatically around them. So that represents itself. If you can reduce, just using one EMR to get some pieces of information, reduce 4,000 mouse clicks to 300 per user per day, the impact is colossal. It's a 90% saving. It's just a proxy for workload. Then there's other things in terms of this. So the saving time, which can mean saving money, depending on how you're paid, whether you're private or public sector, and what kind of, if you have a capitated model and that kind of stuff. Increased access, which means more patients seen per day. Throughput, which means that the number of patients that get through the system per day, and again, it depends on how you get paid as to whether you can turn that into monetary value, leaving to one side all the quality stuff, which is, there's a metric at the bottom. This is reduced neonates, intensive care unit admissions, restraint use, code blues, and I can't even remember what emergency department LWOBs are, but apparently, thank you very much. But reducing them is therefore a very good thing, because you don't want patients to leave without being seen, because that means that for a real person like me, I've gone to a hospital and got so fed up with waiting, I've gone somewhere else. And if you can reduce those by 40 to 7%, you're doing something, and you're doing something for people, which is my central message here, I guess. There's an awful lot of technology in what I've said and what you're going to see, but fundamentally, this is about people's lives. So that's my very general introduction. Thank you very much, sir, for the explanation of the LWOB, which I think for me, that's right. You're adding great value. So LWOB for me is a character in a Star Wars film, but there we are. So we're going to hear about two examples now. Esther's going to talk about a case study, which is an example of the central one. And Teek, we call him Teek because we can't say his real name, he's going to talk about the connected operating system, which is a sort of distributed system. So I'll now shut up, put my mask on, return to the desk, and you're on.
It's been a long day. Hi, everyone. I'll just quickly introduce myself. My name is Esther, and I lead the Command Center business in Europe. So as John mentioned, quite a lot of expertise and on-the-ground knowledge of how real-time applications are making a change in hospitals, particularly in the in the NHS, which is the case study that I'll share with you today. I think this is it. Okay, as John mentioned, you've seen these applications can be used either in the central command center or virtually. You saw some examples of virtual ICU rounds, and these were particularly keen during COVID, when staff couldn't gather together in that physical space, so others would join in from home, from their remote offices, whilst those in the hospital could present and work together with them. The use case I'll give today, again, as John said, will be based on Bradford Teaching Hospitals, and they have a physical command center space, which has a team co-located, and I'll give you some examples of how they're using these applications and how the project started, how it's going, and also what impacts that they've seen to date. So I'll tell you a little bit about Bradford. Bradford is in the north of England. They see quite a vast, group of patients, have about 900 beds. Again, you see on here, seeing about 130 A&E attendance annually. So in our terms in the UK, it's considered a fairly large hospital. It has about 3 different sites and 1 community hospital. So Bradford is, again, one of the biggest in that region, and a lot of patients are transferred to Bradford with very complicated or complex cases. Our partnership with Bradford started in 2017, when, just as any hospital, they realized that there was congestion in A&E, their waiting times were going up, they were having to cancel electives, staff burnout, like John said, multiple sources of information, really uncoordinated care, and this is their language, I'm not even making this on their behalf. Really uncoordinated care, there was no single version of the truth. You could arrive at the same things of 20 different ways. So Bradford and our partnership started really with the goal of solving this issue. Together, we came up or developed a solution that's past these 3 bullet points. So we agreed to design real-time applications that gave them the information that they needed at their fingertips at the right time, help them with the change management and the process changes required to adopt the tools. I think you will all be familiar, there are a lot of projects that get started with all the best intentions but never gets used. So with Bradford, part of the work stream was really, how do we get this adopted? What processes do we need to change to make sure that this solution works and it works at the optimum? Another main line of work was to build their command center space. So this is also something that we helped Bradford with. What does this space need to look like? Who needs to sit in the space to, again, be able to get the maximum benefit from the tools? And also, how should the screens look, even down to what offices need to be in there, what facilities need to be there. So this was quite a large transformation program that we started with Bradford. I think before I get into the detail, just a little bit on the results that they've seen. We categorized into 3 main buckets. So operationally, I'll start with the first one. They now have a hub for decisions and crisis management. During COVID, their central command center space was where they had all their silver and gold meetings, because the information on the screens, it being real time, provided value and saved time that they would have otherwise spent gathering this information, really only for it to be out of date by the time they have that meeting. The second one I'll highlight is the fewer phone calls. So one issue that we saw in Bradford was that the process of placing a bed or admitting a patient was very cumbersome in that, there had to be about, maybe 20 different phone calls. So you have the ward ringing the management team, you have the management team ringing ED, ringing transport, and through the tiles and through the work that we did, saw a significant change in that. Clinically, they have a tile called Deterioration Tile, and what this looks at is patients who have assessments that are not complete. So again, I'm sure I'm talking to clinicians in the room or others who will understand. As per guidelines, you're supposed to assess a patient with a time frame. So what the tile does is highlight when this is not complete, and like John says, gives you actions or directs you to what to do next. And through that tile, Bradford had seen an improvement in the number of complete assessments. Culturally, this goes without saying. The teams are working together now. They now have a shared focus, shared information that they can all see and understand and analyze. They're making decisions based on data. You know, Bradford, again, from where they started to now, there is a culture of change management. To get a project started in Bradford now is a lot easier than it was 2 years ago. I was there from the beginning, and getting a project team started was honestly one of the most difficult things. But now, because they've gone through this transformation and seen the change, it's actually made it easier now to suggest projects to get people on board, because they actually can see the benefit of going through something like this. As I said before, we started in 2017. It was due to be about 18 months, but COVID happened, so we had to adjust our timelines, and obviously that added on. The main point I want to make on the screen is the blue section is the analytics one, right? So based on what we're here to talk about today, you would expect that the entire project was focused on IT, on building the applications. But what I really want to highlight is the change management around this. So you see there's a stream of sort of governance, staff engagement, the constant communication, as well as down here, the process and the capacity optimization. So these are work streams that we started from the beginning with Bradford staff, again, coaching, helping them understand what was coming, how to use the tools, just so that we get to the end and they adopt the change. And I think that is one of the most important things around a program or a project like what GE delivers. I think, again, just thinking through the scope of work that I've described, you would expect that a program of this sort will require the support and sponsorship of your key decision makers. Yes, we work directly, and on the right, you will see we work with with clinicians. We involve your nurses, doctors, operational managers in the projects. They help design the tiles, they help design what actions you take. But ultimately, for kickoff, for the vision to be clear, we work directly with the steering committee. And in Bradford's case, their C-suites formed the steering committee, and they drove the project from start to finish. They still meet once every month, even though the project is technically complete, because there's still projects that are coming out of this work, the transformation project. Continuous improvement is continuous, right? So they still meet to drive the vision and to drive that piece of work. As I said before, part of the solutions that we worked with Bradford on was deploying 8 real-time applications. Now, I won't go into detail about every single one of these, but what you will see is they span the entire patient pathway of the non-elective, right? So from your ED admissions through to inpatient and discharge, there is an application that's focused on each aspect of that pathway. So there is a capacity tile, which I'll show you in detail, that looks at capacity and demand in real time. You then have your ED expediter tile or your ED status tile that's focused on what is happening in real time in my emergency department, which patients need my attention, and what do I do about it. You then have patient transfers, discharge, care progression. That looks at once the patient has been admitted, how do I make sure that they have a seamless journey and that they don't have any significant delays waiting for things like radiology, waiting for pharmacy, because that is what adds up to your length of stay, right? The decision is made by clinicians, the request is put forward, but no one is attending to it, and 2 days later you find out that that request is still sitting there, and that's added quite possibly unnecessary 2 days to the patient's journey. I spoke a little bit about Bradford's physical space. So just to highlight, is about 1,000 square foot, has 15 stations, seats multiple staff, and the 8 tiles I mentioned are the 8 that you see on the screen. What you don't see as well is a conference room that's used to host multiple meetings, and offices where you can have more one-to-one personalized meetings. And it's built in a way that you can see the screens from all angles, because again, if you're having a bed meeting, if you're having gold or silver command, there's no better place than having these screens in view, because at a glance, you can really see what's happening in the hospital. I mentioned the Bradford's command center seats of co-located multiple teams. These are all groups that were previously in the hospital. There's nothing new on here. They just worked in different spaces with a slightly different focus and under different teams. So in developing the central command center space, all these groups were co-located, again, with the single view of expediting patient care and making sure that patient flow is as seamless as possible. I think one I'll highlight on here is that they have a medical director in the command center. Now, this is not universal by any means. The example Teak will give you another perspective, but Bradford has a medical director in their command center, and his role primarily is help resolve clinical conflicts and clinical issues, such as prioritizing which patient to accept next in transfers. So that person serves quite a significant role. I mentioned their meetings held in the command center. Again, I won't go through the list here, but one that I will definitely highlight is the bed capacity huddles. I'm sure this is one that you're all familiar with. This is the meeting you have maybe twice or 3 times a day, and will require staff collecting this information manually, right? Sometimes requires ringing the walls to confirm what the bed states are, or clicking through your EMEA or your bed capacity system to pull that information. In Bradford's case, they run this with their capacity expediter tile. With the help of that real-time information, they've been able to decrease how often they run these meetings, because these are web-based tools, which means you can access them no matter where you are. So there's really no need to call a bed meeting unless there's a problem. And there are very obvious indicators on the tile, and I'll show you as to what they define as a problem. What is the pressure in the hospital? And by that standards, how often do we need to bring the teams together? Oh, sorry, pressed the wrong button there. So this is the capacity expediter tile. Bradford's version looks exactly like this. Obviously, due to PHI, patient information, we can't show you the real thing, but Bradford's tile looks exactly like this. And like I said, what it does is in real time shows you what is the census, what is my occupancy, how many available beds do I have, and under that available, what is clean, what is dirty, what has already been assigned, and then in total giving you the available beds. It also then predicts, so you see the net beds on the right, which unfortunately you can't see clearly, but the net beds is a prediction of how many beds you have available based on the predicted income and outgoings. So how many patients are we expected to come in? How many discharges are we expecting to go out? And then based on that gives you a calculation of what your bed state is. Sometimes you can get a negative number in there, right? Because you have more incomings than outgoings. And that is one of the indicators of pressure that the teams will take action on. The example you see there is a hover. So on all the numbers, you click on and you see more information. So on the unassigned beds, in the example you see just then displays where are those beds, how many, what is the availability, and in some instances it gives you of when they will become available if they're not currently. At the top, this is a new addition to the tile, and this is the pressure indicator based on sort of multiple algorithms that gives you at a view how is the hospital looking. So your ED is at amber in this example, which means that they have quite a significant number of patients in the waiting room, quite a large group waiting to be admitted. And again, the pressure indicator at the top is used to make operational decisions. Are we on divert status? Can we accept new patients? ED looks like he needs help. Can we make more room in our assessment units? It is used to make those decisions. It's one of the places on the tiles that is looked at every single day at the beginning of every shift, again, to make that decision before the team sort of disperse. I'll go back. On this slide, you will see that the tile is grouped by specialty or service level. In Bradford's case, obviously, they have your standard medicine, surgery, oncology. If you click on either one of these rows, it then, nope, wrong, sorry, my apologies. It then opens the individual wards that make up that service line. And what this screen is often used for is whether to identify beds. So imagine the case of a bed manager who receives a phone call that there's a patient expecting to come in. In this view, they can see that, okay, looks like CVSSU has 2 unassigned beds. They can click on that, see exactly which those beds are, and assign that to the patient. And this is all in real time. As she's clicking on that, if a patient is admitted and someone else takes that bed, the tile will update to give them that real updated view. So again, it's really stopping that ringing around, piece of paper writing information, roaming around in a hospital, again, only to have out-of-date information, because by the time you come to your colleagues and you're ready to have the discussion, it's already 5-10 minutes, and a lot can happen in that time. There's also, I think I'll go through this very quickly, a settings view. So in addition to just your standard beds, if you wanted to see sort of beds in the hospital with ventilators, you can. And this was one that was, again, very useful in COVID, because for those critical resources, which is your side rooms, negative pressure beds, or beds that had, or rooms and beds that had ventilators, you could very quickly open up a screen that gives you locations of all those beds, as well as who is occupying those. So again, and I can't stress this enough, this is a simple tile, but it has really made the lives of the case managers and the bed managers in Bradford extremely easy, because at a glance, they can really identify and know what is happening without the ringing around, without begging their own colleagues really to be transparent. And this all happens in real life. People hide beds. I mean, you know, I think I don't have to explain that, but it really does happen. This is non-Bradford tile. So I've showed you the scalable capabilities of the tile. This screen here, we have 3 hospitals on the same tile. This is one that we're working with Bradford to develop to incorporate their other sites. So same information grouped by hospital, and if you click on any of those arrows, it would open the similar view to the one I showed you before. Now, this is great for a system, right, that manages transfer between those individual sites. Just wanted to show you as one of the capabilities that is up and coming, but again, in a climate where integrated care system may actually be one of the only solutions towards some of the issues that healthcare is facing. A tile like this that can give you in real time availability of resources, it's really worthwhile. This is a quote from Bradford's CEO, and to avoid sort of paraphrasing, I'll read this out loud as is written. Operating during COVID-19 has really brought into sharp relief the value of a command center approach, where it is possible to get an organizational-wide view of what is happening operationally across the trust from a single central location. Now, this was important before COVID, but as you can imagine, during COVID, when you're managing patients coming from ED, you're managing phone calls from your national team, right? How many beds do you have? How many beds do you have? Having that single view in one place that you can just position yourself was invaluable. To finish us off, I have a short video from Bradford, so you can hear directly from one of the staff from the hospital.
The command centre is designed to give us a single version of the truth in real time. It gives us a live commentary on how many people are coming into the emergency department, where the demand is, the prediction of where the patients need to go, but also the bespoke area allows us to hold our site meetings 3 times a day. It brings together teams of people and has allowed teams that maybe didn't previously speak to each other or spoke on the phone but never actually visibly saw each other. It's brought them together, so you've got that team spirit across the organisation.
Okay. That brings it to an end for my section of the case study. I'll hand over to Teak.
Hi, everyone. My name is Teak. Very nice to be with you. So Esther explained a perspective on a command center that's very centralized. I'm going to give a perspective on a little bit different form of thinking with a decentralized model, much more focused on frontline staff. So when we talk about this idea of a connected operating system, what do we really mean by that? Operating systems are very much the same in many different hospitals. It's caregivers getting together and having multidisciplinary rounds where they focus on patient care, discuss items around care progression, but then there's other meetings and activities that happen every day in the hospital as well. Those include huddles, whether there's practices to expedite different kinds of activities. For example, we need to get this image done very quickly, or therapy needs to see this patient before they can discharge. And as well as shift handoffs where nurses and doctors have to relay information to one another at end of shifts and things like that. Now, while these operations happen every day at every hospital, in this use case, I'll show how all of this happens on one program, an app, or as we call it, a tile called Patient Manager. This hospital is HCA Mission. They're a 6-hospital system in North Carolina in the United States. And for this case study, our goal was to improve throughput and quality for the organization, totaling a little over 1,000 beds, 90 ICU beds, roughly 20,000 annual surgeries, and many, many ED visits. And as Esther had mentioned before, to do some work like this, it's very large scale and it requires leadership from all levels of the hospital. So we integrate with C-suite leaders frequently and also have a care team that actually carries out this work as we engage and deliver this kind of work. So a little bit about the daily operating system at Mission Hospital specifically. These are some of the activities that happen every single day or sometimes weekly at the hospital. So as you're very familiar, multidisciplinary rounds happen every day. These are generally physician or nursing led. That's where units come together and cross-functionally discuss care for their patients. Additionally, every day at 8:30, Mission Hospital has an executive discharge huddle. This is where the chief operating officer, the chief nursing officer, and the chief financial officer get together and have a discussion around all of the patients that have discharge orders for the day or might be potential candidates to discharge that day. Additionally, there's a lines and drains huddle every day at the hospital. This is where nursing leaders get together and discuss patients who are on central lines, who are on PICC lines, mid lines, catheters, Foleys, different forms of lines to make sure those patients are not at risk for catheter or blood infections. They have a long length of stay huddle. For this organization, it's a strategic initiative to meet every day to discuss all of the patients who've been with the system for longer than 10 days. This is where leaders get together and have that discussion to perhaps come up with a strategy to help these patients transition from the system. They have an observation management huddle. These are those patients who are under assessment and trying to have a plan in place for them within 24 to 48 hours is very, very important for the organization. So that's something that they meet Monday, Wednesday, and Friday to align on as well. And lastly, there's this idea of practices. Practices are things all of our hospitals do every single day. How do we make sure that the imaging priority that I'm focused on right now aligns to the discharging strategy of the hospital for that day? Similarly with therapies, how do we schedule dialysis to help facilitate discharges and get the best use of our dialyzing capabilities? And this hospital has a discharge lounge. That is a space where inpatient beds can be discharged to a separate location in the hospital. And this allows for the hospital to better utilize those inpatient beds while these discharging patients are recovering and getting ready to transition from the system, whether it's waiting for a ride or something like that. Now, all of these things happen, again, in hospitals all of the time. I will go ahead and sort of explain how all of this happens on one tool in real time. The interconnected thread that Patient Manager allows lets hospital caregivers do all of this activity in one place. So while the model is a little bit more decentralized than the one Esther explained earlier, there's actually close-knit communication methodology that still happens with this disconnected model because there's one source of truth, and that source of truth is enabled by Patient Manager. So this is the software. To orient you a little bit to the software, it's called Patient Manager, and as you can see to the very top, each of these is 3 different rows. Each row is a patient in the hospital. And so every single patient in the hospital is on this tile. It's used for many different applications. As you can see to that drop down there, there's these things that we call profiles. Profiles are snapshots at different patient populations with different clinical indications or different clinical criteria or activity that might be present for those patients. But each row is a patient, and on the left, you'll see details about that patient's demographics, who they are, what their date of birth is, age, what diagnosis that they've entered with, as well as details about their gender, their level of care, and their inpatient or assessment class. To the left of that, you'll see critical dates and flags for the patients. These are dates that everyone needs to know all of the time. Whether you're a physical therapist or you're an imaging lead or you're a bedside nurse, you need to know how long that patient's been here with us. So dates like admission dates, anticipated date of discharge, that's the date care teams coordinate together to plan towards, to shoot towards something to help this patient transition from the hospital. You'll notice there's actually an algo. I'll go into that a little bit in detail as well. At Mission Hospital, their data science team actually developed a algorithm to predict when patients like this have gone in the past. So it analyzes all of the patients historically within like a 5-year time period and tries to match patients who have similar diagnosis and similar imaging requirements and similar outstanding labs and makes a prediction on where this patient might discharge, whether it's home, whether it's to a nursing facility, whether it's to rehab, etc. Below those dates, you'll notice these little icons. These are flags. They indicate different things about a patient. For example, this one that you see here with that circle going backwards, this is indicating that this is a patient who has a history of a readmission at the hospital. So many important dates. And then as we move more to the right, you'll see there's a disposition trajectory. This is what the care teams think the patient is going to disposition to. So that first patient is slotted to go to an inpatient rehab facility, and the second to a skilled nursing home. And then lastly, the last two columns to the right of that are pending tasks and completed tasks. What's great about Patient Manager is that all of this information is flowing over in real time from the EMR and many of those other data systems that John had alluded to earlier. This is the ability to now take all of that activity from all of these different data sources, put it in one place to allow decision-making easier for our staff who are already stressed. So you'll see pending tasks like therapies. That first patient needs to be weaned off of oxygen. Completed tasks, you'll see they have check marks next to those tasks as well. So that first patient you can see has already had a stat lab that's been collected. There's a CT that's already been read by the radiologist. I think a specialist is also consulted on that patient. So this is Patient Manager, information about every single patient pulling from many different data silos, organized in a meaningful and clear way, with things that you can do with it. For example, if you actually look at this patient here, they have a DCO. That is a discharge order. That discharge order was written 10 hours ago, and it's read because that patient is still with us. So like that image of the GPS navigation, which kind of let you know there's one thing you need to do. Red is bad. It doesn't get lost because you know that this patient's been here for a while. You could even filter this tile if you wanted to patients who just have red discharge orders, our longest standing orders for discharge. So that's the general sense of Patient Manager. It's very easy to facilitate many different rounds, huddles, facilitate handoffs because it's one source of truth that everyone is using at the hospital, and it encourages collaboration. So units are communicating with case managers, and they're communicating with their colleagues in therapies, they're communicating with imaging, and everyone is on one single thread of information in real time. And just to explain something Esther mentioned as well, developing these software tools and then implementing them requires large-scale change. It requires some time. This is just to iterate that there's a lot of thought that goes into the rollout of these things. Not only is there the development of the application, but it's equally important to train the staff as well to be able to use the tool, whether there's any necessary process changes that need to go in. Oftentimes, we'll work with the organization to bring in what we call expediters. These are experienced nurses and other clinicians who have lots of experience in this kind of work, and so we train them on the tools, and we define actions and roles of how all of this fits together for the broader connected operating system. And I just wanted to call out this idea of concierge. What we found in our experience in doing this at many, many hospitals is just implementing a software and then just saying, you've been trained, here's a document, please go do your job now, isn't necessarily always the best case. We've found that having the GE team there with the caregivers every day for an extended period of time to shadow and learn all of the processes and the complexities that caregivers deal with every day is essential in making sure the details of the tile design and the implementation are on point. So the GE team always is in the trenches with the staff to understand the problems as we try to solve them over a large scale. So back to this idea of an interconnected operating system. There's unit rounds or ward rounds that happen every day. There's huddles that happen every single day. Practices are being expedited, but how do you really do that? How does that work in one tool? And I'll show you some of that now. So this is the view you had just seen before. The focus on this view is to support a ward round or a multidisciplinary round of some kind. As care teams gather together, whether that's around a screen like this, or it's at a nursing station like this, or oftentimes if the organization or the ward has capacity, maybe even in a conference room, where everyone is looking at the same information, updating in real time, discussing those patients together. One feature I want to call out on this is that algorithm that I had alluded to. So we can see the second patient here. The algorithm is actually predicting 38% of the time patients similar to this patient have gone home, and historically patients similar to this one, 28% of the time have gone to a nursing facility. Having that kind of real-time information early on when the patient presents themselves, we found really helps caregivers have a nuanced and meaningful conversation from day one in how to start planning for that patient's care. But the theme here is each patient is discussed, their anticipated date of discharge is collaborated on, updated, and their pending tasks a plan is put into place to address those. And from that point on, what's great about this tool, the real-time aspect of it all, is that once it gets updated here, it's updated for everyone. So if therapy, for example, is looking at their patient list, and all of a sudden we thought this first patient was going to be leaving tomorrow, but now it seems that they might be able to leave today, and that date is updated, that automatically prioritizes itself closer to the top of the imaging queue so they can logic off of the rich information and the discussions that are happening at these ward rounds. So that's one flavor of how you can use Patient Manager. If you'll see on that drop-down list there, those are many different profiles that have been created. Patient Manager allows you to choose from many different profiles that exist in a library, and users also can create their own to look at information that they want to look at themselves. So there's a little bit of customizable ability for each user to make Patient Manager their own. Going to a different use case of a patient manager at Mission Hospital. If you recall, I had mentioned that executive discharge huddle where the chief operating officer, chief nursing officer, and the chief financial officer get together every day. Historically, it would take an administrative coordinator an hour before the meeting to gather all of the patients that might be discharging, already have a discharge order for that day, or those that might be discharging tomorrow. Now with Patient Manager, in one click, they can pull up this list very, very quickly. So what this does is a very similar view to the rounding view, but this is all of the patients who have a discharge order today. And here they use this profile for a quick 15 minutes every morning to align as an organization on what actions need to be taken to ensure a smooth transition and smooth discharge activities. So one example of a huddle. Another example of a huddle that's particularly of interest to this organization is trying to address patients who've been with the organization for an extended period of time. And again, it required 2 nursing assistants every day, on average about an hour and a half, to go through the EMR and their capacity management system and use an Excel spreadsheet to then calculate, admit date minus today's date to figure out how long these patients have been here. And now with Patient Manager, you can configure whatever date you want. This is set to 10 days before. This profile gets saved in that profile dropdown, and when nursing leaders have their long length of stay huddle every day, they just go to that dropdown and now have a list that they can work to identify these patients. Before, that process required many manual entries during the actual huddle itself. It happens in about 15 minutes and is always a few clicks away just from their profiles. Another example of a huddle that's very important to this organization at Mission is the ability to have a proactive plan for patients on varieties of lines and drains. So this view actually allows you to see all of that. This patient, for example, has been on a Foley for 7 days. This one's been on a midline for 2 days, PICC for 6 days, and a dialysis catheter. They are really interested in reducing acquired infections, and this is another profile that they use to drive their huddle every single Monday, Wednesday, and Friday. So those are some examples of huddles. Another example of a huddle, I forgot there was one more, is to be able to identify patients who've just come into the organization who are under assessment or under observation. So you can see that it's very easy to identify patients who've been here for longer than 24 hours, as well as 34 hours. This gives caregivers a very quick shortlist of the 27 patients in the organization right now before they reach that 48-hour mark. How do we come up with a proactive plan to either discharge the patient or consider converting them to an inpatient level of care? So those were huddles. Now to the idea of expediting practices, obviously imaging, therapies, labs, they all also have their work to do, and while they might not be on the units every day, the work that they do is also very, very critical to planning for throughput and relieving capacity constraints and things like that. So here's an example of the list that their imaging organization looks at every day. These are the 3 patients right now who have a discharge order, and that over there in the yellow box is the outstanding imaging activities that are still yet to be done. So you can see some of these patients are waiting for the scans themselves. So the opportunity is to transport the patient, whether it's to an ultrasound or an MRI, or is the bottleneck really with the read? The image has already been completed, but we're waiting for a radiologist to complete that read. So this allows the imaging department to prioritize their work, and it also helps the organization drive throughput and capacity because it's prioritized by the patients who are discharging and sorted in a way that you see the oldest discharges first. Another example of an expediting practice, I had mentioned that this organization has a discharge lounge. It is an area in their hospital that has 40 different pods, and these are generally patients who are discharging, most likely going home. They're not going to a skilled nursing facility or some other level of care where they can receive ongoing, more critical care. What we did with this organization is we actually designed an algorithm that considers different clinical aspects of those patients. So if they are mobile, if they're comprehending instruction, if they don't have COVID infections, if they don't require any form of isolation, generally patients who are ready to discharge, who can go to the discharge lounge, this algorithm actually does a lot of processing and applies smarts to those patients' clinical criteria and recommends who those patients might be the best candidates for the discharge lounge. So historically, staff would be burdened and have to make many different phone calls. The wards would be calling the discharge lounge would be calling the wards. There would be a lot of unnecessary phone calls and conversations, text messages, chats on the internet. And now all of those have dramatically decreased or have been essentially eliminated because the discharge lounge, every day their attendant, who's a nursing coordinator, comes in, pulls up their profile on Patient Manager, and they know how to work directly with transport to transport these patients directly to the discharge lounge. So another example of an expediting practice. To share some of the results, this has been work that's gone on for about 6 months with a little bit of pause to allow the organization to focus on their higher COVID rates. But we've facilitated and revamped rounds on over 40 different units. 5 huddles have been redesigned with leaders and staff alike to use Patient Manager to be driving those huddles. We've aligned with many different ancillary services like therapies, imaging, staff from the discharge lounge. One of the big organizational goals or metrics that Mission Hospital is striving for is higher EDD rates, that's estimated or anticipated date of discharge. When we started this work, it was at 60%. It's increased to 87%, and we've sustained that for 6 months. The discharge lounge is something they wanted to get a lot more utility from. We've gone from 25 patients a day to 40 patients a day going through their daily. And incidentally, out of the 186 hospitals in the HCA family of hospitals, Mission Hospital is now the best performing out of all of them. And just, we know how busy staff are. They're already burdened with COVID and just the sheer brilliance that goes into taking care of patients every day. So when we want to present them with the tool, we want to make sure it's something that they like using, they find meaningful, and they believe it's an extension that provides better care for their patients. So we surveyed 110 of those caregivers, and 90% preferred the revamped MDR methodology using Patient Manager. And just to share an anecdote from another institution at Tampa General Hospital, that's the acronym TGH, they're more mature in this kind of work, and we've been doing this kind of work with them for over a year. They've reduced their length of stay from 5.3 days to 5 days, with over 30 of 40 units improving. And then lastly, just to give you an idea, this is actually all of the profiles of executive leader at HCA Mission. She uses all of these different line items, which are many different profiles. We just saw 3 or 4 of them, but as you can sense, the possibilities are sort of endless. She uses many of these things. For example, if I want to have a COVID huddle, show me all of my COVID positive patients very, very quickly. So all of these enable different kinds of activity within that broader connected operating system. And what we found is there's generally a natural owner for one of these, but as each of these line items is worked by a natural owner, that information that's put into the tile or derived from the tile falls on many different eyes because all of that information is interconnected. And so we found the staff really have found that it makes their life easier not to have to call someone when they can just go to a different profile and see what their colleagues have put in real time every day. And just to read a quote from Tricia, the executive leader there, "Seeing critical activity within the health system in real time allows me to drive many of our daily operations. It creates a common source of truth for care teams and replaces the outdated paper forms and spreadsheets we used to rely on." A little bit about the software. Now that you've seen what Patient Manager can do, I do want to explain a little bit how this is all working together. Our software platform, the Command Center software platform, whether it's the centralized applications that Essert alluded to with Capacity Snapshot or the ED tiles deterioration, or Patient Manager, which you just saw, all of those are Command Center software platforms, regardless of the use case of a central command center or a decentralized model. But the way this really works is all of this data exists in silos within the EMR. So the patient record holds a lot of information. There's anesthesia information. There's information about upcoming procedures, labs, pharmacy. We ingest all of that data from the EMR, as well as other workflow systems. So whether you use a staffing system like Kronos or others, whether there's a PAC system where image data is being stored for MRI and CTs, or oftentimes even other devices like monitors or wearables that you might have on a patient. We ingest all of that information, generally through HL7 APIs, sometimes FHIR, and we apply a lot of our own smarts. This is the power of AI that we develop in-house. Sometimes we'll partner with data science teams at existing clients to pipe in some algorithms that they believe to be really strong. We'll partner with them to power our tiles. And what we do is we're very source agnostic. So what that means is we can make this work with any EMR. So whether you're on Cerner, you're on Epic, something homegrown, we can synthesize data from all of those places. We apply logic on top of it, and then we merge that into a single data layer that powers all of our tiles or applications. And on the back end, we have the ability to do retrospective reporting or any kind of business intelligence operation, so they can be dashboarded using Power BI, Tableau, any kind of reporting mechanism. Click, I think we've used sometimes as well. And lastly, we have the ability to communicate to unified comm systems, whether it's to push to pagers, whether it's to HCA Mission uses a platform called iMobile. So when critical activities escalate, they can get pushed to phones and things of that nature. So this is really how the technology works on the back. I will turn it over to John for some last remarks.
Last remarks. Follow that. Stand there for a minute. So, yeah, I don't know, ladies and gentlemen, who do you think's got the better tie? I think me on average. Well done, Chief. Yeah. So there we are. There is an awful lot of technology there, but it isn't really about that. You can give anybody a heap of technology and things won't improve. This is, yeah, good point. This is about improving, changing the way that people work. If culture is the way we do things around here, then this technology enables hospital leaders to change the culture of the hospitals they manage. So we're in GE. GE is a great company which does stuff. It's very sort of big in healthcare, as you'd expect, in many other fields as well. We work with a focus on care. We work collaboratively. We're with a big focus on implementation and change management and on innovation. And maybe you saw some of those dimensions in what we talked about. I think, and you can deliver these benefits, which is almost repetition in a way. It's about you can do great things for your hospital by taking advantage of the potential that technology has to deliver. You can do this by yourselves. The technology exists already. It will take you years. And that's the thing. I would recommend working in partnership with somebody to help, or like Tang Tok Seng in Singapore, a fantastic place, beautifully well-led hospital from everything that I've been able to see. They're 14 years in the making, as opposed to 5 months in the making. So working with a partner who knows about this stuff can be a great accelerator for you in doing all that stuff. So, that's it.
I have one question.
Yes, we'll turn over to questions now, and I beg your pardon, maybe the lady, were you asking a question first? No, you weren't, I beg your pardon, it's a noise I can hear through the door.
Yeah.
The disadvantage of masks. Yes, sir.
Give two examples that you are 180 degrees different from each other. One is NHS in England. Their goal is to reduce costs. The other one, HCA, which I know them very well. You are a for-profit to maximize profit. Okay. My question to you is, what is your return of investment? If I come to you and say, I want to buy this, what is the return of investment that I should be looking at?
So it depends on how you measure that investment, but these things, if you're investing in a GE command center approach, unless it's changed since I was very closely involved, they'll pay for themselves within the first 18 months.
First 18 months?
Yes. And I would say on top of that, by the way, it's, I believe very strongly that whoever does this, and if you're considering or anybody else is considering do this, don't be seduced by the technology alone. And I'm sure I'm preaching to the converted here, but I think for every dollar that you spend on the tech, you should spend another dollar on the change management, because it's cultural change enabled by technology. And giving people the smartest, what do you call them? The smartest smarts in the world by itself, it doesn't work. Thank you. We're at the end of our thing now, I think. There may be a final slide or something or other, but this is from a chief nursing officer at a command center site. How to fight and win the daily patient care battle. This is about reducing her stress and the stress of her colleagues and helping people's lives in doing so. Does anybody have any other questions or anything else? I'll return over there wearing my mask, obviously. Does anybody have anything else? Oh, I don't know how to switch this on. Oh, gentleman with a nice yellow tie.
Hi. Well, thank you very much. All presentations were very engaging, and I wish I didn't have jet lag. It's something that we, my institution, have gone through these COVID times. Is not necessarily knowing the beds and managing the beds. That's kind of the easy part. Not knowing that we have the human resources to do something is what is really, really grueling, and we have found that very, very difficult to assess, mainly because we don't know where it's going to hit us. So my question to you is, what is the adaptability to this tool for you to manage your human resources in a way that you can anticipate stuff or respond to them more quickly?
So I'll start and then I'll hand over to Teek. So one, managing workload. So the whole concept of this, really, to my understanding, is matching capacity and demand. It's matching those two things predictively. As part of that, matching the staffing roster, how many doctors, how many nurses you know that you will have for the coming week or weeks or whatever, with accurately forecast predicted demand. That's already built into some of the tiles. We can do that. The other part of it, however, and maybe I haven't answered your question because I can see you're shaking your head. The other part of it is that I'm struck by where I've seen command centers in the world, how people talk about how it's transformed the place, made it a better place to work. The way to many of my friends and colleagues who are chief execs or CFOs of different hospital organizations around the world, the thing they're most worried about is how to attract and retain staff. And in my experience, it's simply by making it a better place to work. So that's it's sort of the medium to long-term answer, is to do something like this, and it really does help. Now, does that answer your question, sir? And if not, I might defer to my elegantly betide colleague.
In terms of the staffing to demand, we do have a software that I think John was referring to called Census and Staffing Forecast. What that does is we build a model with the organization to predict the census of your organization based off of historical data and some other logic, to predict the census of the organization for today, tomorrow, all the way up to 14 days. And then we marry that census capability with the staffing for the organization all the way up to that same time threshold, and we identify opportunities in the future where you are understaffed or overstaffed based off of the predicted census of your organization. So what that allows is gives decision makers, especially in staffing offices or executives, the ability to know that in 4 days from now, Unit 5 is going to be short 2 nurses and 1 nurse is also called out. It gives me enough lead time to flex my scheduling dynamics to act accordingly.
So you're actually modeling that?
I'm sorry?
You're actually modeling that?
Yes.
And this is actually in use as we speak. So there are a couple of hospitals in the US that actually use this tool daily.
Duke University is a major hospital system in the US that uses this every single day.
What university?
Duke?
Oh, Duke.
You do that based on your productivity model.
Yes.
And in the state of California, you have a mandated nursing staffing ratio, which is completely different from the other states.
100%. We configure that based off of the hospital policies.
Yeah, this isn't a one-size-fits-all kind of product. Every single one of them is different, but with the same underlying technology. Good. Are there any other questions?
Just one comment here. John, I was quite impressed. When you started, your first words were, we'll talk about stress, the necessary, how it should be helpful to relieve the stress. And you ended here by saying, reducing her stress. Thank you for that.
Thank you. Okay. Well, with those great words, which are only repetitions of words I use myself, therefore, thank you all very much indeed for your attention. And I think we can draw this session to a close. I'd like to thank my experts very much for coming from around the world as you did. So well done, you two.